Yeah.
Good evening, everyone, and welcome to the next session of the PHO online teaching program. And as you know, we alternate months where we have hematology in 1 month and oncology topic in the next month. And today we have a topic, it's called More to It Than Meets the Eye. And thrombocytopenia is one of the most commonest referrals that we get in the clinic. And to throw light on it, we have eminent speakers who have joined us. And first, it will be Dr. Vinay, who's a consultant pediatric oncology at Manipal Hospital, Bangalore. And then we will have some case discussions, which will be presented by Dr. Ranjita, who is a FNB fellow at St. John's Medical College, Bangalore, followed by comments from Dr. Anand Prakash at the end, who is a professor and head at St. John's Medical College, Bangalore. So without further delay, I think Vinay, if you can start.
Hi, am I audible?
Yes.
I'll share my screen. Is my screen visible now?
Yes. Can you put it in full screen?
Yeah. Is it in full screen now?
Yeah.
Okay.
Perfect.
Good evening, all. It's always very nice to be speaking along with all the senior colleagues, teachers, as well as the PHO trainees. So let's start off this session. So the first part of the session, I'll be talking briefly about approach to thrombocytopenia in children. So I'll divide my talk into 4 stages. First, we'll set up the stage of thrombocytopenia, then try to do algorithmic approach and stepwise approach for thrombocytopenia, and then look at some masqueraders of ITP with some clinical clues, and then talk about what is in store and the way forward. So this is William Osler, who described what a platelet is. He described first platelet as the third corpuscle of the blood in 1883, and he told that these are pale granular masses which are half the size of white blood cells, but it can vary in size as well. And when it is examined without any reagents, filaments and fibers stick to them. So this was the first description of the platelets. From then to now, what we know is the electron microscopic ultrastructure of platelets, which says there are 4 important parts of platelets. The membrane, which actually hosts all the receptors for the platelet adhesion aggregation. Then the structural zone, like actin and myosin filaments, which help in contraction of the platelets. Then the canalicular system, which release the granules that are stored inside the platelets, and the storehouse of the platelets, which are the alpha granules and the dense granules that are stored inside the organelles. So we know that platelets are the primary responders of primary hemostasis, the first responders. So whenever there is a vessel wall injury, platelets are the first ones that go and stick to the vessel wall injury. That is called adhesion. Then they release few things and contract themselves and then adhere to each other, which is called activation and aggregation. So once that is done, primary hemostatic plug is formed. So now let's talk about how to approach a child with thrombocytopenia. So just few definitions. Thrombocytopenia in kids, we know normal platelet count is between 1.5 to 4 lakh per microliter. We define thrombocytopenia as platelets less than 1.5 lakhs per microliter. But in ITP, the specific definition is platelet count less than 1 lakh per microliter. But are these numbers important? What are the important clinically relevant platelet numbers that we often think of? Platelet counts more than 50,000 is usually asymptomatic. Less than 50,000 sometimes have skin bleeds, and it is one of the causes for surgical bleed. A thrombocytopenia with a surgical bleed may come at even 40-50,000. Platelet counts less than 20,000 may come with spontaneous mucosal bleeds, and less than 5,000 can have risk of intracranial or systemic bleeds. However, numbers are not very particular for the risk of bleeding, but this is just a arm measure. So platelet type of bleed is a primary hemostatic bleed, and usually the symptomatology that we see are epistaxis, skin bruises, petechiae, oromucosal bleeds, and bleeding after trauma, menorrhagia in adolescent girls, and surgical event. Usually deep or soft tissue bleeds is not a part of thrombocytopenia type of bleed. So how do we do a structured approach for thrombocytopenia? First and easy clues are, first we should know whether it's a clinical thrombocytopenia. Is it the child has presented with petechiae and purpura, or is it just a laboratory thrombocytopenia, asymptomatic child? The next important thing is I always look at whether the child has presented in an outpatient or whether it's an inpatient one, based on which we can classify the good, bad, and the ugly types of thrombocytopenia. The ones that resolve quickly are the good ones, like childhood ITP, nutritional anemia, sometimes presenting with thrombocytopenia, and some viral infections, which usually are transient thrombocytopenia, transient myelosuppression that settle. These are the good ones. They are usually seen in outpatient. And few of them may take time to resolve, but they are not life-threatening. These are the ones that present with autoimmunity or marrow-infiltrative disorders like leukemia, and sometimes inherited thrombocytopenia syndromes, which may have mild, moderate thrombocytopenia, which may worsen over a period of time. The ugly ones are the ones that present inpatient in a critical stage, like HLH, DIC, HUS-TTP, and sometimes platelet refractoriness, post-transplant thrombocytopenia, graft versus host disease, and things like that, which are usually the ugly ones. So coming to the first step of algorithmic approach, it's always important to know the clinical picture of the child. So it's better to enter the clinical details in a pre-structured proforma for any bleeding disorders and in thrombocytopenia as well. So it's very good to note the age at presentation, the demography or the ancestral history from where the patient is coming, and the clinical details, the type of bleed, what has been the nadir platelet count, and has there been a previous documentation of platelet count, what is the drug history, and what is the family history. So this is the historical aspects that we should concentrate when we see the child. Then subsequently, see, one of the important ones with importance to demography or ancestry is that we see a lot of kids coming in our clinic from northeastern states of the country who are asymptomatic but present with moderate thrombocytopenia. This specific subtype is called congenital asymptomatic macrothrombocytopenia, also named as Harris platelet syndrome, or sometimes called Bengal platelet syndrome. Usually it is autosomal dominant, and the parents' platelet count also is low, but they are always asymptomatic. So it's good to know one of the first questions we always see in asymptomatic child low platelet count is to ask from where the child is coming. The few clinical clues that we always ask for when we think about when we see a child is whether the child is presenting with fever, bone pains, pallor, lymphadenopathy, hepatosplenomegaly, lymphoreticular system involvement, where we think about leukemia, myelodysplasia, or some marrow-infiltrative disorders. If we have symptoms like joint pains, photosensitivity, rash, alopecia, oral ulcers, then probably a rheumatological illness. And other things like a syndromic child, short stature, dysmorphism, and more than one cell line involvement may be an inherited marrow failure. Neonatal onset ones, usually we classify them as sick or non-sick thrombocytopenia, based on which we think about the probable etiology. Hemangiomas may present with Kesebeck-Merritt syndrome and thrombocytopenia. Few of the neurometabolic conditions less than 2 years old can present in the ICU, like organic acidemias with thrombocytopenia or other cell line involvement as well. Now, following these clinical clues, we always have to, the next step is to ascertain whether it's true thrombocytopenia. A child coming with a platelet report showing a low platelet count. First thing is to look whether it's really a thrombocytopenia. So sometimes artifactual thrombocytopenia can be seen. So here comes the importance of blood smear. So this is the peripheral smear where there is platelet clumping because of EDTA. The EDTA actually sensitizes the platelets and exposes the GP2B3A receptors, and there is platelet clumping. And there is something called platelet satellitism because of the platelets clumping around the activated white blood cells. These account for pseudothrombocytopenia. Whenever we are seeing a smear, we should always ask our pathologist whether the platelets are small or large in size, which can be measured in terms as compared to the white blood cells and the red blood cells around, and see. It's good to see the other cell lines as well in the peripheral smear, like presence of cystocytes and thrombocytopenia may be indicating towards something like a HUS-TTP spectrum. So how do we try to remove the pseudo-thrombocytopenia pre-analytical variables? If there is clumping because of EDTA, citrate vial can be used. Sampling technique should be good. A free-flowing blood sample should be taken, and always ask for a manual platelet count. And the step 3 is again evaluate the peripheral smear because it gives a lot more answers than any other test. So when there is true thrombocytopenia, just see whether it's a single lineage involvement or multi-lineage involvement. If it is a multiple lineage involved, bicytopenia or pancytopenia, if there is presence of cystocytes, it may be indicating towards a HUS-TTP spectrum. Blasts may blasts and nucleated RBCs or leukoerythroblastic picture may suggest a marrow pathology. Hemolysis is also evident, maybe suggesting towards Evans syndrome. And so always talk to your pathologist when you are looking at, when we have to see a child with thrombocytopenia and we do not have a diagnosis upfront. So these are few of the clinical peripheral smear photos. The first one is a large platelet, and that may be seen in Bernard-Solier. MYH9 related syndromes are also macrothrombocytopenia syndromes, but they also have nuclear inclusions, which is shown in the picture. And some of the conditions like gray platelet syndrome may have hypogranular platelets. So important is talk to your pathologist, ask for a manual platelet count, check the morphology of platelets on the smear. Mean platelet volume also should be considered. Neutrophilic inclusion should be specifically asked for if you're suspecting. Look for any abnormal sense and any signs of hemolysis. This will give us a lot of clue about which way are we heading towards in our diagnosis. Next step will be evaluation of isolated thrombocytopenia. When we do not have a systemic cause and we end up, again, we follow the same algorithm to look at the isolated causes for thrombocytopenia. We all know that the commonest cause for kind of stable isolated thrombocytopenia is immune thrombocytopenia. If we see, maybe we see about a lot of children coming to us with thrombocytopenia or ITP, but I always think it's a paradox because it's the commonest cause of isolated thrombocytopenia in childhood, but it's always a diagnosis of exclusion. So we have to run through the entire algorithm before we label the child as ITP, and it is always good to know what is the classical clinical presentation, and if we are deviating from the classical presentation, should we think something else. So usually ITP presents abruptly, acute onset, and usually it is severe thrombocytopenia. The age is between 1 to 10 years. They usually present with minor bleeds like skin bleeds or mucosal bleeds, and the treatment needed is often less. So whenever there is more than 2 or 3 lines of treatment used within first 6 months of treatment for ITP, we should always think whether we are seeing it correctly. And most of the times in childhood ITP resolves, and there should not be any atypical signs or symptoms. We know how we classify ITP, newly diagnosed, persistent, and chronic. So when do we evaluate for secondary causes of ITP? Whenever the child is persistent or having chronic ITP, or there are some atypical presentations upfront. So what are the usual workup that we do for secondary causes? That we do immune constitution workup where we send immunoglobulin profile, TB, NK subsets. We do some autoimmune workup like ANA profile, sometimes double negative T cells for ALPS and DCT. And viral workup as well, wherein sometimes viral infections can cause smoldering thrombocytopenia, and bone marrow evaluation. So this is a recent review series in ASH, which talks about an update in ITP, at the same time differentiating it from inherited platelet disorders or primary immunodeficiency disorders which present with thrombocytopenia. So this is a very good article, and I would ask all the residents to read it. So it provides a very good algorithm for evaluation of thrombocytopenia, and one of the things that it highlights is whenever in doubt, there are 2 subsets that we have to consider in a chronic ITP kit. So one is whether it's an inherited platelet disorder. Another one is whether it's an autoimmune condition or something called primary immune dysregulatory syndromes which presents with autoimmune thrombocytopenia. So when to consider a diagnosis, reconsider a diagnosis of ITP. So one is age of onset. If the age of onset is less than 2 years, and it is chronic and persistent, not getting better with usual lines for 1 or 2 lines of treatment, we may have to consider inherited platelet disorder. The age of onset more than 10 years and being chronic and not being controlled or resolved, maybe there is some immune dysregulatory syndromes underlying. If there is no previous documented normal count, then also we may have to think about an inherited thrombocytopenia syndrome if it is not getting better. Familial thrombocytopenia, that means if we see thrombocytopenia in the kid not getting better, the parents also have thrombocytopenia, we may have to consider things like Harris platelet syndrome, X-linked autosomal dominant thrombocytopenia. Moderate thrombocytopenia, ITP usually presents severe thrombocytopenia. If there is moderate, it may be marrow pathology or hypersplenism, or it may be sometimes platelet function defects or an evolving marrow failure syndrome, and may not be ITP. This is very classical, very high IPF or high MPV, more than 13 femtoliter, IPF more than 25%, may indicate disc megakaryopoiesis, and there may be a marrow pathology or evolving inherited platelet syndrome that may be there, and need for multiple lines of treatment where we may have to reconsider our diagnosis of chronic ITP. Some literature from where there has been a revision of diagnosis from ITP, is one of the largest registry from the Europe, where called PARC ITP study. It's a multi-centric European study. 15-year registry, 2004 to 2019, 3,974 kids with the diagnosis of primary ITP were evaluated, and it was seen that the revision in diagnosis was done in 113 patients, and mean time for revision of diagnosis was about 12 to 24 months. And the common secondary causes was autoimmune infection or immunodeficiency. So whenever we have a child who is nagging and requiring multiple types of treatment as chronic ITP, we may have to reconsider our treatment. So two other publications, the McMaster ITP registry, where misdiagnosis of ITP and frequency of bleeding was seen. It's a generalized study, not just a pediatric study. And another one where prevalence of inborn errors of immunity masquerading as chronic ITP was seen. So one of the papers suggested that 1 in 7 patients suspected to be having primary ITP was misdiagnosed at some point of time, and they had approximately 56% of them had grade 2 bleeding. So kids who are symptomatic and chronic ITP, we may have to reconsider our diagnosis, and there may be something more to just being ITP. So what are the further clinical clues that we may have to see? So oculocutaneous albinism may present with HLH. So 3 syndromes, Hermansky-Pudlak, Zodiac, Higashi, and Rizzoli. Recurrent infection, eczema, Wiskott-Aldrich syndrome. We have to look for microplatelets. Skeletal defects have their own syndromes. Then Evans syndrome, DCT positivity at autoimmunity may be heralding some autoimmune disorder. DCT positivity in a chronic ITP child, in a child with ITP, usually indicates that the ITP is mostly chronic. So this is one of the things that has been described in literature. For more than 20% of the kids with DCT positivity tend to become chronic ITP, even if they do not clinically present as Evans. Then hearing difficulty, early onset cataracts, renal abnormality may be MYH9 related syndromes, and leukemia, cancers in family may indicate towards familial platelet disorder with myeloid malignancy predisposition, autoimmunity, gray platelet syndrome, and things like that. This is another review article published in Pediatric Blood and Cancer 2020, where they talk about what a pediatric hematologist and oncologist should know in regards to primary immune regulatory disorders. The 3 masqueraders of chronic ITP are one is ALPS, second one is CVID-like syndromes, and the third one is combined immunodeficiency, which is late onset. So usually there will be CVID has low immunoglobulin levels, ALPS have normal immunoglobulin, but the double negative T cells are increased, and the late onset CID, like combined immunodeficiency, usually have low T cell numbers. All of them present with immune cytopenias with some other syndromic manifestations. So whenever we are looking, there is utility of mean platelet volume, based on which we can classify them as microplatelets, macroplatelets, or normal size platelets. Severe thrombocytopenia, when it is there, many times MPV may not be accurately obtained on Coulter. So it's good to speak to the pathologist to ask what is the amongst whatever platelets they are seeing, what do they feel, whether it is small or large. So based on the size of platelets, few genetic conditions may be seen. I'll not label all of them. It's a very good paper where they have talked about congenital thrombocytopenias and how they evaluate. So it is syndromic or non-syndromic. The microplatelets are the ones with Wiskott-Aldrich and few others. Then few can present with predisposition to malignancy, skeletal defects, and thrombocytopenia. And there are few thrombocytopenia syndromes with early megakaryopoiesis defects like thrombopoietin receptor defects. Then macrothrombocytopenia are the ones that can present with syndromic in terms of MYH9 related disorders, where they can present with early onset cataracts, glomerulonephritis, and sensorineural hearing loss. Gray platelet syndrome is one thing that can present with myelofibrosis and autoimmunity, and transcription factor defects like GATA1 defects can present with familial thrombocytopenia and a few other genetic causes. So with this, whenever we are in doubt, we may have end up requiring genetic analysis for asserting the diagnosis of thrombocytopenia. But can we do whole exome or just shoot in the dark? Thrombogenomics is one thing, a network that has been developed in the UK, in the Europe, as well as in the North American countries, where they look at specific targeted NGS panel to look for bleeding and thrombosis risk. And it has been validated from the International Society of Thrombosis and Hemostasis, where they look at about 36 genes of coagulation and 25 genes of platelet disorders. And we may end up in few chronic ITP cases, if not like most of them, we usually tend to sail through with the clinical picture of chronic ATP, but 1 or 2 out of 10 may end up requiring few specialized testing, which may include genetic testing as well, where targeted NGS may be better. So what are the take-home messages? A structured algorithmic approach to be emphasized. Common clinical conditions are more common. Masqueraders of chronic ATP may need specialized tool to identify. There is a need to establish a nationwide registry to understand the pathogenesis of chronic ATP, which is not responding to usual lines of treatment. And I think the INFOX studies are underway for looking at genetics in few of the chronic non-responding ITPs. Thank you.
Thank you, Dr. Vinay. I would now request Dr. Ranjita to please share her screen and continue the presentation. Meanwhile, I would request everybody to put their queries in the chat box. We will discuss all the questions at the end of the session.
Thank you, Vastev sir. I thank IPPHO and my mentors and colleagues in St. John's Medical College for giving me this opportunity. Over the next 30 minutes, I'll be running you all through a series of cases which were referred to us in the diagnosis of chronic ITP, but on further follow-up and evaluation was diagnosed to have a different entity. Without wasting much time, starting on to my first case, this is an introductory picture which shows various stages of maturation and differentiation of the platelets, starting from the common myeloid progenitor cell, megakaryoblast, and further on. Coming to the case one, we had a 10-month-old male child who was first born to third-degree consanguineous marriage couple at term, who presented with fever since 4 days and a history of blackish discoloration of stools 15 days back. He did not have any history of loose stools, abdominal distension, any stigmata of metabolic disorder, vomiting, yellowish discoloration of eyes, growth failure or bleeding elsewhere in the body, or any medication intake. With the past history, the child was noted to have fever spikes and pedicle spots on day 20 of life, which was evaluated and treated as late onset sepsis. And similar episode was noted at 4.5 years of age, with the 4.5 months of age, which was diagnosed to have, which was evaluated with CB's complete hemogram, which showed low platelet count. But both the times he was discharged on clinical improvement with no further evaluation of the disease. And family history, come to the family history, he did not have any significant history of bleeding in the family. On examination, a moment, sir. On examination, the child had pallor with petechial rashes noted all over both lower limbs. Other head-to-toe examination was within normal limits with no obvious dysmorphism or neurocutaneous markers, and his vitals were stable, and systemic examination was normal without any organomegaly. And the complete hemogram of his showed a hemoglobin of 9 gram, with total counts and differential counts being normal, and the ANC of 3040. And the platelet fraction of 2.1% and the mean platelet volume slightly on the lower side of 6.9 femtoliter. So pelvis smear was requested, which showed normal morphology of RBCs and WBCs, and platelets were markedly decreased. And the other evaluation with coagulation profile, liver function, renal function, tests, serology, and ultrasound abdomen and stool for occult blood turned out to be normal. In view of presentation in infancy, that is 10 months, and male in gender, born out of consanguineous marriage couple, significant past history of recurrent infection and thrombocytopenia, which was detected outside, differential diagnosis of Wiskott-Aldrich syndrome was considered, and immunoglobulin levels were sent. But immunoglobulin levels were within normal limits with lower limit of normal IgG levels. A trial of IVIG was given and then discharged after symptomatic improvement. But on serial follow-up, thrombocytopenia persisted with recurrence of ecchymotic patches on follow-up. So hence, with the disparity in the clinical symptoms and lab investigation, clinical exome was sent, which turned out to be having MPL gene deletion, which was homozygous and autosomal recessive in inheritance, diagnosed to have congenital A megakaryocytic thrombocytopenia. So this child is currently on supportive care, and he is planned for hematopoietic stem cell transplant. Moving on to my second case, This is a 3-year-old male child, first born to third-degree consanguineous marriage couple at term, who presented at 1 year of age with on and off bleeding from gums and bluish discoloration of the skin since 2 to 3 months, and history of blackish colored stool at 2 years of age. With this complaint, the child was evaluated at another pediatric hemato-oncology unit, and there also he did not have any history of fever, abdominal distension, loss of milestones, vomiting, yellowish discoloration of eyes, or recurrent infection. Family history was significant. There was no significant history of bleeding though, but the mother had recurrent third trimester intrauterine depth for reasons not available. And for this, the child was evaluated for the same at an pediatric hemato-oncology unit and detected to have persistent low platelets. The child received platelet support for the same on multiple occasions with recurrence of symptoms within 2 to 3 weeks. So on examination, he had mucosal bleeds with pallor and multiple ecchymotic patches all over the body, and there was no desmorphism or neurocutaneous markers. His vitals were stable, and systemic evaluation revealed nothing other than normalcy. And with this, the child was also evaluated at other pediatric hemato-oncology unit, where hemoglobin was 6.7 with total counts of 8,100, differential counts being 10% of neutrophils on 81% of lymphocyte, and the absolute neutrophil count was 850, that was moderate neutropenia, and a platelet count of less than 5,000. On this, the peripheral smear was requested, which showed normal morphology of RBCs as well as WBCs. The WBCs were normal in total number, but the differentials were low, and platelets were markedly reduced in number. The other screening parameters, like coagulation profile, liver function, renal functions, serology, and TORCH profile was normal. And chromosomal breakage analysis was also requested, which was negative. Bone marrow evaluation was done, which showed hypocellular marrow with normoblastic erythroid maturation, increased lymphocyte, and a decreased megakaryocyte with increased iron stores. Trephine was also collaborative with the same. So with this history and clinical examination, genetic evaluation was done due to early age of presentation with bone marrow failure symptoms. So this showed MPL deletion with homozygous and autosomal recessive inheritance. So the child was diagnosed to have congenital amegakaryocytic thrombocytopenia. But in comparison to the previous child, the first case that I presented with CAMT did not have any neutropenia or leukopenia, but this child had already evolved into neutropenia, which warranted emergent hematopoietic stem cell transplant. And the child underwent haploidentical hematopoietic stem cell transplant because the child did not have any sibling, and the MUD, that is matched unrelated donor workup, was negative. So the child underwent haplo HSCT with the conditioning regimen by fludarabine, cyclophosphamide, melphalan, ATG, and total body irradiation with GVHD prophylaxis with tacrolimus and PTCYs. The child is currently day plus 68 post hematopoietic stem cell transplant, and he is doing well with day plus 60 chimerism being 99.9% with no evidence of GVHD. So a short brief on congenital amegakaryocytic thrombocytopenia. It's a rare autosomal recessive condition which presents with bone marrow failure syndromes with severe thrombocytopenia in infancy without major physical anomalies, and the propensity to evolve into aplastic anemia and leukemia is high. So how does it happen? So as we all know, for the thrombopoiesis to occur, we need the protein thrombopoietin. But how does it act? It should act via the receptor, which is encoded by CMPL. So the thrombopoietin receptor, when it is coded by CMPL in conjugation with TPO, stimulates both early as well as late phases of megakaryocytopoiesis, thereby increasing the number, size, ploidy of the megakaryocytes, and also promotes the expression of platelet-specific markers on the platelets. But not just that, it also maintains number of other hematopoietic stem cells, and any abnormality contribute to the occurrence of both thrombocytopenia and pancytopenia that we saw in our case 2. So biallelic mutation in the gene encoding thrombopoietin receptor, that is CMPL, which stands for myeloproliferative leukemia, results in high TPO levels because the receptor is not functioning and the negative feedback inhibition is absent. And hence, absent downstream pathway is active for megakaryopoiesis is not there. Hence, presence with thrombocytopenia initially and then pancytopenia on follow-up. So coming to the types, there are briefly 3 types, but type 1 and type 2 is well-defined and type 3 is ill-defined. Type 1 has complete loss of functional receptor for CMPL, which and hence they present early in their lifetime with decreased bone marrow activity and very low platelet counts. Usually the platelet counts hover around 20,000. But in type 2, there is partial loss of functional receptor of CMPL, where only the extracellular domain is absent, and there is some amount of intracellular domain of TPO receptor. Hence, they present in the milder variety, and they usually present after 3 to 6 years of age. And the platelet count of these remains between somewhere around 40,000 to 1,30,000. And type 3, it's very ill-defined and they do not have defects in the CMPL. This is the type which has been explored on a larger scale, and any alterations in the genes playing a role upstream or downstream of the receptor is the theoretical hypothesis. So coming to the genetics, type 1 has nonsense MPL mutation, thereby leading to complete loss. But type 2 has missense mutation, thereby causing a milder disease because some amount of intracellular domain of the TPOR is present. So some patients have inherited 2 different mutations of the CMPL gene, resulting in compound heterozygous states. However, a proportion of them may have normal MPL. So this is the variety which is still under investigation. So this is the pictographical representation of the same, where you have the MPL, which is the receptor, which exhibits its action through this JAK kinase as well as tyrosine kinase, where it leads to transcription and translation of various other proteins, thereby leading to survival and proliferation and effective differentiation of the megakaryocytes. So coming to clinical manifestation, they usually present with severe thrombocytopenia reported as early as first hours after birth. On examination, there is characterized by absence of major physical malformation, but with minor malformation of heart, eye, and brain have been reported in few case series. And lab parameters shows thrombocytopenia with normal platelet size, and they're usually negative for chromosomal breakage analysis. Bone marrow classically shows absent or severely reduced number of megakaryocyte, but normal development of other lineage, unless the child has already evolved into myelodysplastic syndromes. However, a few CAMP patients have been reported to have normal megakaryocyte number in the initial bone marrow samples, and hence you should not exclude CAMP from the differential diagnosis of thrombocytopenia when they present with thrombocytopenia in the first few years of life. And high TPO levels usually in the range of 30 to, normal range is 30 to 196, but reported levels of TPO of around 400 to 4,000 have been seen in few research categories in cases of CAMP, except for in thrombopoietin mutation, where the thrombopoietin itself is absent, and hence they have low levels of thrombopoietin. So common differentials as per the age will be thrombocytopenia with absent radii, in which you can definitely rule out the cause with associated skeletal hypoplasia of the arms. Prescott-Aldrich syndrome, as we saw in our first case, but however, the microthrombocytes is one of the features which helps in narrowing your diagnosis. Neonatal alloimmune thrombocytopenia, which resolves with age, and Fanconi anemia, which is always associated with congenital anomalies. So management. This management remains same for all the inherited thrombocytopenia that I'll be covering today. So usually they require depleted, irradiated, unrelated donor platelets, avoid general precautions like avoiding NSAIDs and utilizing antifibrinolytic agents. There are some theories where cytokine therapy as well as colony-stimulating factors have been attempted, but there is transient response and later loss. No role of anabolic steroids or corticosteroids, TPO agonists, and immunoglobulins. Definitive management is usually hematopoietic stem cell, in which the matched sibling donor is preferred over MUD over haplo. As per the reports, 5-year overall survival is almost around 80 to 90%, but sibling needs genetic screening of the donor, even if sibling have a normal platelet count, and always be aware of TPHO mutation, which is usually responsive to TPO agonists and do not require bone marrow transplantation. And prognosis, it is one of the congenital bone marrow failure syndrome, which present in the neonatal period, which evolves into aplastic anemia, although the mechanism is unknown so far. Moving on to my case 3, here I present a 12-year-old female child, second born to non-consanguineous marriage couple, who presented with recurrent episodes of throat pain since 3 years of age. And she was evaluated by ENT team and diagnosed as chronic tonsillitis, and she was electively posted for tonsillectomy. There was no history of fever, rash, joint pain, or swelling, bluish discoloration of eyes, yellowish discoloration of eyes, and growth failure or bleeding in oral cavity or elsewhere in the body. No history of any medication intake. Past history: when the child was subjected for pre-anesthetic evaluation for tonsillectomy, she was incidentally detected to have low platelet count, hence was referred to us for evaluation and management. And family history-wise, father has past history of low platelets, which was attributed to dengue fever with no bleeding manifestation. On examination, the child had pallor with hyperpigmented patches over the arms, which was petechial rashes on different stages of recovery. And on head-to-toe examination, the child had grade 4 tonsillar hypertrophy, adenoid phases, and one insignificant caffeolate macule on the right forearm. Rest examination was within normal limits with no obvious dysmorphism. Vitals were stable and systemic examination was normal without any organomegaly. Her complete hemogram revealed hemoglobin of 10.7 with normal total count and differential leukocyte count. And ANC was also normal, but platelet count was 14,000 with an immature platelet fraction of 67.5%. And peripheral smear showed normal RBC and WBC morphology with few reactive lymphocytes which was seen, and platelets were markedly decreased with occasional giant platelets was noted. On other evaluation, coagulation profile was normal, liver LFT, RFT, and serology was normal. Anemia profile revealed iron deficiency anemia. Chromosomal breakage studies were done in her because of the age of presentation, and it was negative. And the child also complained of persistent headache. To rule out intracranial bleed in the background of thrombocytopenia, NCCT brain was done, which was normal. Bone marrow was done, which suggested cellular marrow with normoblastic erythroid maturation and an increased megakaryocyte. As the IPF was high, breast workup was negative. Child was given a trial of steroids and IVIG in an attempt to normalize platelet for her elective surgery. But on serial follow-up, thrombocytopenia persisted, and with his previous history of father having low platelet count once, his platelet counts was repeated with us, which showed 40,000 platelet counts with other hemogram being normal. With disparity in the clinical symptoms and lab investigation, significant family history, clinical exome for inherited thrombocytopenia was sent, and the child was started on TPO agonist for the benefit of doubt. But fortunately, her platelet count improved to over 1 lakh after 2 doses of bromiplastin, and genetic reports was back by then, which was suggestive of MYH9 mutation, which was heterozygous and autosomal dominant in inheritance. And she was diagnosed to have macrothrombocytopenia and granulocyte inclusion, with or without nephritis or sensorineural hearing loss, which comes to the topic of MYH9 related disease. What is this disease? It is usually autosomal dominant in inheritance, which usually present with moderate to severe macrothrombocytopenia. It's usually caused by missense mutation of what? But it is about the myosin chain. So few cases with sporadic as well as somatic germinal mosaicism has been reported. So myosin 2A is a protein which is required for many other systems. So where all is it expressed? It is expressed in platelet, cytoskeleton, kidney, and inner ear of the inner ear cilia, which and hence MYH9 related disease will often become symptomatic with age. So myosin, in particularly 2A and 2B, are involved in proplatelet formation by interacting with the actin filaments, which is required for generating the contractile force. Myosin, the heavy chain of non-muscle myosin 2A, encoded by the gene MYH9, is required for budding of pre-platelets and subsequent separation into platelets from the megakaryocytes. However, whenever there is mutation in the MYH9, it leads to reduced synthesis of non-muscle myosin 2A, which leads to a loss of fragmentation of the pre-platelets, leading on to promoting the formation of reduced number of large platelets. That is why macrothrombocytopenia terminology is noted. So why do they bleed? There are various reasons as to why do they bleed. One of the reasons being reduced clot stability due to impaired clot retraction by platelets with a disturbed cytoskeleton, hence predisposing them to bleed. Second, lacking contractile force, megakaryocytes shows reduced migration to the vascular sinus together with altered proplatelet formation, resulting in reduced platelet release in the marrow itself. And thirdly, the large size platelets are channelized in the center of the blood vessel, resulting in a lesser chance of interaction with the damaged endothelium, and hence leads to poor hemostasis plug formation. This is the pictorial depiction of the same, in which these are the normal size platelets, which are small in number and they are closer to the endothelium and hence have better interaction with the damaged endothelium when it is damaged. But In cases of this MYH9 related disorder, when you have macrothrombocytopenia, they have less number of platelets which are in closer approximation with the endothelium, and hence less hemostasis is achieved. Coming to the clinical presentation, they present with wide spectrum of clinical features, commonly having macrothrombocytopenia with variable degree of bleeding tendency. They might also have associated renal impairment and varied age of onset of cataract and hearing loss. So diagnosis, they usually diagnosed by evaluation of platelet and granulocyte morphology. And with the platelet, they usually large platelets with high MPV and a broad platelet histogram, and have a peak preceding the leukocyte histogram. And this should raise the suspicion of MYH9 related thrombocytopenia. The other test is cytochemical or immunofluorescent detection of the inclusion bodies, which are dole-like bodies in the leukocyte on the blood smear, which facilitates the diagnosis. So this is a representative picture in which you can compare and contrast A and B, in which A has comparatively, this is the deceased picture, and you have a relatively larger platelets with less number of thrombocytes, in comparison to slide representative B, in which you have comparatively more number of platelets which are tiny. And this is a picture, the arrow pointing towards the hole-like inclusion body, which is seen in the leukocyte. So screening also includes an audiogram to see your sensory neural hearing loss, ophthalmological screening for cataract and renal function evaluation for glomerulonephritis, and treatment is mainly supportive. And there are other syndromes under the umbrella of MYH9 related disorders, which was previously thought as separate entity, but now they all come under the umbrella of MYH9 related disorders, to name the May-Hegelin anomaly, the Epstein syndrome, the Fechner syndrome, and the Sebastian platelet syndrome. Moving on to case 4, here I present an 8-year-old male child. Again, this child was evaluated at another pediatric hemato-oncology unit and referred to us for second opinion. He is an 8-year-old male child born out of non-consanguineous marriage couple with uneventful perinatal history, adequate vaccination, and normal developmental milestone. He presented to that center with multiple ecchymotic patches all over the body over a period of 1 week with no history of fever, trauma, or bleeding elsewhere, or joint swelling. Previous history of dengue fever was there, but with good clinical recovery in stipulated time. On examination, he did not have any lymphadenopathy or organomegaly, and his first CBC revealed hemoglobin of 9.1 with total counts of 4,390 and platelet count of 10,000. The child was diagnosed provisionally as ITP, and he received IVIG for the same. But on follow-up, CBC showed hemoglobin of 7 and total counts of 3,800, but this time ANC was 460 and platelet count was 24,000. And retic count was 0.5%, leading on to a pancytopenic picture. And his IPF was low, 3.8, with MPV being normal. And peripheral smear showed normocytic normochromic anemia with reduced platelet counts, for which the child was evaluated with bone marrow biopsy, which showed hypocellularity for his age with decrease in all the cell lines, and was then diagnosed to have aplastic anemia. But the child had a significant family history. So the maternal grandmother, the mother, and the maternal aunt, along with his cousin, had a history of thrombocytopenia, which was not evaluated. However, the maternal aunt required platelet transfusion during her childbirth, but none of them had any severe bleeding manifestation, which required any evaluation. So with this, during this time, the child received platelet concentrate as per bleeding profile, and the workup for aplastic anemia was instituted with the chromosomal breakage study was negative, and clinical exome was sent. But on serial follow-up, hemoglobin showed stabilized at 8.9 with total counts of 3,090 and ANC still neutropenia, and platelet count were 38,000. And the child developed, again persisted to have ecchymotic patches with no mucosal bleeding. So hence, awaiting the genetic report, wait and watch policy was instituted and was under close follow-up. And CBC after 1 month showed hemoglobin of 9.6 and total counts of 5,630. And ANC had improved to 1,600 and platelet counts of 41,000 with no visible ecchymotic patches. At this point, we were thinking in terms of dengue-associated cytopenia. In view of significant family history of thrombocytopenia across 3 generations, evolution into aplastic anemia, suspicion on inherited bone marrow failure syndrome was high. Hence, the genetic workup was sent, which turned out to be RUNX1 mutation, which was heterozygous and autosomal dominant in inheritance, which was pathogenic. So currently the child is on regular follow-up since 2 years now with every 3-monthly CBC and general thrombocytopenic precautions. And thrombocytopenia is still persisting with no mucosal bleeds or evidence of pancytopenia. And we had done a baseline marrow evaluation which showed no evidence of dysplastic changes. So moving on to the next topic, familial platelet disorder with predisposition to myeloid leukemia. So what all are the genes which are implicated under this? Firstly, RUNX1, which is our index case, ETV6, ANG-RD26, and CAMT. So RUNX1 associated familial thrombocytopenia. So what is this RUNX1? It is a transcriptional factor which interferes with the early stages of megakaryocyte maturation and is often accompanied by a risk of developing myeloid or lymphoid malignancy. It is first shown in autosomal dominant thrombocytopenia that these mutations can also lead to myeloid or lymphoid malignancy. And this RUNX1 is the master regulator of hematopoiesis, which is transcribed on the chromosome 21q. So what are the salient features? There is significant phenotypic heterogeneity, as we have seen in our child as well. They usually have present with mild thrombocytopenia with mild bleeding profile and normal MPV with defective platelet function. Why? Because there is reduction in the granule secretion, more of dense than the alpha granules, and hence they have aspirin-like functional defects. And sometimes this megakaryopoiesis can be noted on bone marrow evaluation. And significant family history of malignancy and thrombocytopenia should alert a clinician for this diagnosis. And how does it run the risk of myeloid leukemia? Germline RUNX1 mutation interferes with the ploidy and prolongs the expression of a cytoskeleton protein MYH10, which leads to switch from mitosis to endomitosis, resulting in an abundance of immature megakaryocytes that fail to differentiate properly. So in the background of decreased DNA repair, pro-inflammatory environment, and prolonged life of a hematopoietic stem cell, it predisposes the patient harboring this mutation to acute myeloid leukemia and related condition with 44% lifetime risk. This is the pictographical representation of the same, where the RUNX1 is implicated early in the megakaryocyte formation and maturation. Diagnosis is usually genetic test, which identifies the pathogenic variant in RUNX1 and it confirms the same. And hematopoietic stem cells in the pre-leukemic patient, that is in our child, remains debatable due to transplant-related mortality and incomplete penetrance of the disease. In patients with hematological malignancy, hematopoietic stem cell transplant may be indicated as per the underlying malignancy. And caution is to avoid the HLA matched relatives who may also be carrying the familial gene variant of as donors. So surveillance, there is very less literature on the same. Physical examination with CBC with differential counts biannually suffices usually. And on any abnormality in the CBC, it warrants a bone marrow evaluation for the same. Moving on to my case 5. Here is a 12-year-old male, first born to third-degree consanguineous marriage couple, presented with history of multiple episodes of bluish discoloration of the skin associated with spontaneous resolution since early childhood. So he also significant past history is the child also had recurrent dermatitis, which was not evaluated. And he didn't have any mucosal bleeds, fever, connective tissue disorder, stigmata, joint swelling or pain, recurrent infection or poor growth. So, and family history, it was not significant. No history of similar illness or bleeding manifestation in other family members was noted. On examination, there was no pallor or lymphadenopathy, but he did have multiple ecchymotic patches all over the lower limb, which were non-palpable. No feature suggestive of dermatitis or neurocutaneous markers were noted, and systemic examination was normal. So outside, we had a CBC count, which was showing his platelets count varying between 60,000 to 90,000. With male gender and early onset of presentation, that is with early in childhood, and with recurrent episodes of infection in the form of dermatitis, but not having any systemic manifestation, Wiskott-Aldrich syndrome was suspected. And hence, he was evaluated on that same lines. But his hemoglobin revealed a hemoglobin of 10.7 with normal total counts and differential counts, and his platelet count under us was 57,000. And peripheral smear showed normocytic normochromic cells with few normocytic hypochromic target cells and electrocytes. WBCs were normal in number and distribution, and platelets were decreased. Other evaluation was within normal limits. And he was investigated in lines of serology, ANA, immunoline, immunoglobulin levels, as well as PID workup, which turned out to be negative. And he was subjected for bone marrow evaluation, which showed cellular marrow with normoblastic erythroid maturation, increased eosinophils, and increased megakaryocyte. Workup for other causes of chronic ITP was done, which was negative. Since the child didn't have any mucosal bleeds, wait and watch policy was instituted and was under close follow-up to monitor for the evolution of other signs and symptoms. But on follow-up, the younger sibling of the index case presented with history of recurrent epistaxis from 5 years of age. Hence, with significant family history, index child was subjected to exome sequencing for inherited thrombocytopenia, which reported as FIB1 mutation, which was homozygous and autosomal recessive in inheritance and was pathogenic. And the younger sibling who presented with epistaxis was also subjected for the same mutation, and he also harbored FIB1 mutation, which was homozygous and autosomal recessive in penetration. So a short note on FIB1 mutation, it is one of the most recently discovered genes known to cause inherited thrombocytopenia, with autosomal recessive in inheritance and characteristically has small platelet thrombocytopenia. The exact effect of the mutation is yet to be determined, and a postulated hypothesis is a role in megakaryopoiesis have been suggested due to reduced percentage of mature megakaryocytes in the bone marrow. So this figure highlights where that FIB1 is implicated in the defective megakaryocyte differentiation and maturation spectrum of megakaryocyte differentiation. And this slide emphasized that this is one of the novel thrombocytopenia mutation that has been recently discovered in a decade. And this is one brief report which shows the deleterious mutation in FIB1 gene, which is associated with congenital autosomal recessive small platelet thrombocytopenia. Unfortunately, the index child was then diagnosed to have classical Hodgkin's lymphoma 2 years post this mutation detection. However, the child is currently under treatment for the same and responding well. So a research review of literature was done to know if this gene is also implicated in congenital hereditary cancer predisposition syndromes. And there was one report which says that FIB1 promotes the progression of T-cell acute lymphoblastic leukemia. I now move on. I hand over the screen of presentation to my mentor, Dr. Anand sir.
Thanks, Dr. Ranjita. I think what we'll do over the next couple of minutes is, after that very nice introduction from Dr. Vinay and a lot of those cases which were scenarios which we saw in St. John's, I thought we'll sum up by putting down a few learning points. Like Vinay said, whenever we have a child with thrombocytopenia, at the back of our mind, perhaps we always have to keep the thought process, is this something usual or is this something rare? And while historically inherited thrombocytopenias were considered as a group of rare diseases with this very low prevalence that some papers talk about, I think more and more we are all recognizing that this underreporting is because of sometimes a misdiagnosis as ITP. You would have seen how that even in the series of cases which came to us, it's kind of a knee-jerk reaction to say it's probably ITP once we rule out some of the most sinister causes of thrombocytopenia. So I remember Vinay putting down good, bad, and ugly. And I think we should point out that the group we presented today of inherited thrombocytopenias could actually move very quickly from being so-called good to being bad, and actually some of them like the CAMT and other things being actually ugly. And like the RUNX one, which can at any time evolve into a myeloid malignancy. So I'm sure we recognize, just like in inherited marrow failures, there is this evolving and more recognition of various genetic abnormalities being picked up as inherited thrombocytopenias. So I think Ranjita did a great job today by telling us the various steps of megakaryopoiesis and how at various levels of transcription, cytoskeletal proteins, the membrane receptors, signaling proteins, how at differentiation, platelet formation, and platelet release, there are various genes which affect the production and the function of the platelets. So for some of the students in the audience, this review article from Frontiers gives us the whole list and gives a very succinct description of this. This cartoon, which I got from one of the recent blood journals, actually tells us how there are, cellular pathological mechanisms at some of the things which we looked at in our cases today. Some of them, like RUNX1 and ETV6, we are also familiar with in malignancies, of course, play a role in transcription at various cell lines. We are all aware of the MPL mutation of congenital hematopoietic thrombocytopenia, where the receptors play a role. And we saw how Dr. Ranjitha presented the MYH9 and some of the newer entities of FYB, which have a role at the cytoskeleton. This table with such a lot of alphabet soup is kind of hard to remember. So I'm sure when we have a difficult case, we always have to fall back on genetics to try and look at what we are dealing with. So I think great minds think alike, and both my colleague Dr. Vinay and me put down these two slides just to put down that while in some situations you might actually have a syndrome and you might have clues to say that, yes, I have hearing, I have renal, I have Dolly-like bodies, I have a big platelet. In many of the situations, there is no syndrome and there is no other clue, either in the size of the platelet or in terms of clinical features. So if we are really drawing a blank in terms of our evaluation, keeping inherited thrombocytopenias at the back of our mind is probably not a bad idea. So again, even if we have, when we have small platelets, I'm sure you and me, everyone will think of Viscott, but there are more and more entities like the FYB, which Dr. Ranjitha presented today, which also cause small platelets, and the very tricky group of normal sized platelets, which otherwise look normal. Right? So those sometimes could be difficult to diagnose. So when you and I are sitting in the clinic, when do we suspect inherited or hereditary thrombocytopenias? Some of these points have already been covered, but because it's important, I'll quickly go over it. I'm sure you'll all agree that if it starts at birth or starts before 1 or 2 years of age, like what Dr. Vinay told us today, we'll always look back and say, could this be an inherited thrombocytopenia? Family history is easier said than done. Like presented today, often initial history doesn't reveal it, but when we actually start sometimes evaluating asymptomatic family members, sometimes that might actually give a clue. Lack of platelet response to ITP therapies, Vinay also brought out, and you've seen in our patients. I'm sure it's not a sin to give steroids or IVIG to a patient who is otherwise well and doesn't have a malignancy while we are doing the workup. But I'm sure we should all keep a high index of suspicion if, like already presented, 2 or 3 lines of therapies aren't really helping the platelets to come up. Diagnostic features, sometimes on the peripheral smear, absence of the granules, gray platelets, the Dolly-like bodies. If these are there, it is helpful. But like I just showed in the previous slide, many of the inherited thrombocytopenias don't have any of these features. But if these are there, clearly we should not think of ITP. Bleeding out of proportion to platelet count, for example, Bernard-Solier is always well described. And some of these patients would have obvious manifestations like absent radii, mental retardation, renal failure, high tone, deafness. But just I'd like to point out, like I'm sure many of you already know, that many of these patients, even with the MYH group, would not all come to us with the syndrome. They might evolve over a period of time to have cataracts and the nephritis and things like that. So keeping them on follow-up and looking for new symptoms is important. And if it comes up, we need to obviously revise our diagnosis. One of these things which is kind of interesting is a persistence of a stable level of thrombocytopenia. So our patient with the RUNX1, which had come to us for a second opinion from one of the other oncology centers in Bangalore, the mother was very sure that hers, her mother's, her aunts, and her sons' platelets were always hovering between 30, 40, 50, 60,000. So that was probably a clue, to say that this is not an ITP. So Is it really important to give a label to each of these inherited thrombocytopenias? Yes, very much so. We don't want to misdiagnose them as chronic ITP because we don't want to give them unnecessary immune suppression. And God forbid we do a splenectomy for any of these patients. That's obviously not going to help them one bit. For all of these, some of these have important clinical implications like CAMP and the myeloid malignancy predisposition. So I'm sure we would want to give our patients the benefit of an antenatal diagnosis. The malignancy risk has already been brought out today. I already talked about the systemic features. Unless we know it is MYH9, we are probably not going to follow up the other systemic manifestations as carefully as they should be followed. Some of these, like, Ranjita brought out the 2 children with CAMP in the first 2 cases, and some of them actually require urgent therapies. It's probably as urgent as something like, a Fanconi's child with pancytopenia or an acquired aplastic anemia child with pancytopenia. And we all know that CAMP can evolve into MDS and AML. I'm sure we want to transplant these children before they get into those problems. And also, one important point of response to TPOs, because it's not only the ITPs which respond to TPOs, there are other subgroups like the MYH9 and certain subgroups of Bernard-Soulier which can actually respond to TPO. So I think we are just running out of time. So I'll quickly sum up in the last 2 slides. The management, of course, is largely supportive, but keeping in mind that some of these entities may evolve and might need more aggressive treatment. So we've covered the platelet transfusions, and one important thing about platelet transfusions is that we should, as far as possible, to prevent alloimmunization, give matched platelets and also always leukoreduce the platelets so that the chance of medium to long-term alloimmunization for these chronic thrombocytopenias is minimized. We've spoken about transplant for some of these conditions which all of us are aware of. Gene therapy for some conditions like Wiskott-Aldrich is available. This I thought was important for all of us because, like you saw in one of our patients, we didn't really, think of that particular inherited thrombocytopenia, and we said, okay, let's give a trial of TPO agonists, and promptly the patient responded. So if I was sitting in a busy clinic, I would say, okay, this patient with ITP has responded to the TPO agonist, but does that rule out inherited thrombocytopenias? Not at all. We've shown that in our own patient, the MYH9 girl who came in for the surgery responded very well to the TPO agonist. And it's heartening to note that we have some of these agents which can actually be given to children before surgery, or if they're very symptomatic. How long it can be given, can it be given lifelong, is still something which needs to be sorted out. And I think Ranjita brought out very nicely in her presentation how if you have a congenital amyloidotic thrombocytopenia phenotype, we should make sure, is it a THPO mutation? Because those patients clearly don't respond at all to transplant and require just thrombopoietin agonists, which would restore the entire hemopoiesis. So I think I'll stop here by saying that I'm sure we've convinced you that there is more to ITP, you can interpret it whichever way you like, than meets the eye. Thanks to my department, my colleagues, particularly Ranjita, has put a lot of work to put these cases together. And I think I'll close by, I'm sure you know many of these dynamic people in this picture. This is the INPOC platelets and hemostasis thrombosis subcommittee. And like Vinay mentioned rightly, they are rolling out this data set, a much needed data set on pediatric inherited familial thrombocytopenias. And Dr. Tulika, the PI, and my colleague, Dr. Vandana, who is the subcommittee chair, do reach out to them. It would be wonderful if in our own country, we have a registry for all of these familial thrombocytopenias. So I think I'll stop here and hand over to Vasu and Manas. Thank you so much.
Thank you, Dr. Anand and Dr. Ranjita for the wonderful presentation. So I think we will just go through the questions that are posted.
Vasu, I'll just interrupt for a second before we go for the questions, because I know a lot of participants leave while the question answer session is going on. I just want to give a message that please register for FOCON. It is in November 22nd to 24 in Jammu. An exciting program is being prepared. Please register for FOCON. That is one message. The second message is about the next session, which is on 22nd. and it is about tumor microenvironment and how drugs can be used in that different tumor microenvironments, and how chemotherapy can be made more successful for these patients. Vasu, over to you for the question answer.
Yes. The first question Dr. Gurpreet has asked, what is the role of IPF when making a diagnosis of ITP? So, Dr. Vinay, if you can take the question.
Yeah, so IPF is one of the investigation armamentarium we use, but not the upfront investigation. So IPF in ITP, when they have done the studies, and also I think there is a systematic review as well, it says that the IPF is increased in ITP somewhere between 10 to 25%. A very high IPF may not be indicative of ITP, maybe something like a dysmegakaryoparesis, as was shown in one of the cases of RUNX1, where it was more than 65%. The other thing in ITP, what clinically we do IPF upfront, soon after a viral infection. So some most common causes for ITP in kids is a viral infection or post-vaccination. If there is some form of infection suppressing the marrow, and there is some form of autoimmune ITP going on, the IPF may be low. So a low IPF does not rule out ITP. Third thing in ITP is if the patient is on the TPO agonist, the IPF is pushed far higher. So IPF, if we check on a patient who is already on TPO agonist, it comes 40-50%, which means it is a stimulated count that is there. So it is not a diagnostic test, but it can be prognostically used as a marker, which may say when the platelets may recover. Very low or very high should be taken with a lot of pinch when we are dealing with the case of ITP.
Thank you. The next question by Dr. Cindy. Do you have any alternative treatment for amegakaryocytic thrombocytopenia besides transplant and thrombopoietin? Maybe Dr. Anand can answer this.
So I think that's a good question. Thank you for that. I think when we have an amegakaryocytic thrombocytopenia, we do need to get a genetic cause for it. So just a phenotype does not confirm an amegakaryocytic thrombocytopenia. If it is an MPL mutation, which is the classical one, unfortunately, no. At the moment, there are no, stopgap treatments. The sooner we start working up for transplant, the better it is. There are scattered reports of response even in amegakaryocytic thrombocytopenia of response to TPO agonists, but that is not a standard form of therapy. And like we try to bring out today, knowing which mutation and whether it is the problem with the receptor or whether the thrombopoietin itself is not being produced in amegakaryocytic thrombocytopenia is important. Because if it's not being produced at all, then transplant is not the treatment and we would have to go to thrombopoietin agonists. So it's not, could I do this or that? We need to know what the mutation is and then treat accordingly. Because we do know that the commonest type of amegakaryocytic thrombocytopenia, particularly the type 1, would over a period of time evolve to pancytopenia, like was demonstrated in our second case. And some of them would even evolve to have myeloid malignancies, like other inherited marrow failures. So you would want to pick them up and try and work up for transplant and get them to transplant before those actually happen. Thank you.
Thank you. So the next one, I think Vinay can take it. This is by Dr. Srijit. Recently came across a patient with ITP with platelets between 20 to 30,000. Developed cerebral sinus venous thrombosis. He was started on enoxaparin. Please tell me what will be ideal for this patient: steroid, L-thrombopath, or ROMI to keep the platelet count at a safe range, given that he is on enoxaparin. It's a very difficult scenario, but
yeah, I think the first thing is because there is thrombocytopenia at the same time thrombosis, probably we should rule out APLA syndrome. So that is one of the things. So ruling out underlying rheumatological cause or immunological cause is important. We have come across few cases of thrombocytopenia with thrombosis in something called IgG4 related disorders as well. So probably there is some underlying immune dysregulation that is there. So if it is an APLA kind of syndrome, you need to keep the anticoagulation quite high. Otherwise, the risk of thrombosis at multiple areas, especially life-threatening pulmonary thromboembolism, is high. So you should not discontinue anticoagulation. Rather, you should try to keep a safe platelet count. So whenever we are doing enoxaparin with low platelet count, the general dictum is to give full dose if the platelet counts are more than 50,000 and having a normal creatinine clearance. If the platelet count is between 30,000 to 50,000, we usually do once a day dosing or half dosing with a normal creatinine clearance. Less than 30,000, we avoid. But here, I think if there is an underlying immune dysregulation, the child will need a good immunosuppression so that the platelets come up with the immunosuppression, and at the same time, anticoagulation can be continued.
Thank you, Vinay. The next question is actually discussed by Dr. Anand, that is the recommendation of whole exome sequence in case of inherited platelet disorders. But if I think there was a nice slide on the recommendations when to test. But any comments, Dr. Anand, on this?
Yeah, I think in retrospect, many times after we get the whole exome, we are all wise. And then sometimes we take family history and, we find so many family members are involved. But I think, yes, the points which both Vinay and me made were very similar, very early age of presentation, definitely a family history, a so-called ITP, which doesn't seem to resolve with multiple lines of therapy, a very stable platelet count, which is always 40, 50,000 and is not really changing very much. Some difference in the, platelet morphology sometimes is helpful, but I'd like to point out that not all inherited thrombocytopenias would have a difference in morphology. And sometimes simple clinical examination. So, what we do at the bedside, any dysmorphism in the patient, any past history of nephritis, any family history of nephritis, cataracts. So some of those. So I'd refer the students in the audience to that article from which the cartoons were from. It's from Hematologica in, I think, 2022. So it's a nice review on inherited thrombocytopenias, with a lot of molecular details. And since we're all doing more and more NGS, I think we'll pick up more of these and understand the platelet function better.
Thank you, Dr. Anand. The next one, what is the minimum platelet count to run PFA 100? Vinay, would you want to take it?
So PFA 100 is a functional test to see what is the clotting clot strength that is formed. So we need to have a good platelet count to do that. So ideally we should have more than 1.5 lakh, but we can convince the labs to do if it is more than 80,000 to 1 lakh. But I think this is what I know, but if any other comments or Anand sir, if anything. We do not do routinely. We need to have a good platelet count to analyze the data.
Correct. So I don't have access to it here, but at SickKids we did have access to it. So there is one more called now PFA 200. So it's a screening test for, as you know, the more severe platelet functional problems. So yes, at least a minimum of 1 lakh platelet count would be required.
Dr. Deepti has requested a slide on the diagnosis as per the size of the platelet. So Dr. Ranjita, if you can go back to the slide where beautifully, I think Dr. Anand and Vinay have combined and made the slide. So thank you. Meanwhile, we'll take the next question, which is by Dr. Vinita. Next one, patient should HSCT be done before progression to MDS AML? So I presume this is a patient with thrombocytopenia in which we have found a RUNX1 mutation. Should HSCT be done before progression to MDS AML?
So that I think I'll take that question because we had the patient. I think there is no consensus across the world on this topic. When the child came to us, we all had a lot of discussion. And the challenge is that we don't know when the patient will evolve. Like this child we presented, the mother, the aunts, the grandmother, all have the similar thrombocytopenia, and none of them have had AML. So I'm not really sure that we should rush into transplant. The current guidelines from some of the groups is that, like presented today, check the counts relatively frequently. The suggestion from them is once in about 6 months. And at the slightest change in any of the 3 counts, a repeat marrow would be indicated. And then to proceed with the definitive treatment. So I'm sure the person asking the question is also concerned that they want to take up for transplant before the evolution to MDS. But we don't really know for how many years this child will remain stable before actually evolving and whether he will evolve at all or no. So I personally would not offer transplant unless there's a change in the counts. What was tricky for the team which what was tricky for the team which initially saw the child was that the child following the dengue had a pancytopenia. And so at that time when they did the marrow turned out to be hypocellular. Subsequently, all the counts of the child have been okay except the low platelet. So I don't think this child is, actually evolving at the moment. Thank you.
Thank you, Dr. Anand. The next question is from Dr. Shrikant. 8-year-old diagnosed with chronic ITP, refractory to multiple medications, TPO, dapsone, azathioprine, cyclosporin, platelet counts between 50 to 20,000 with skin bleeds. Whole exome sequence showed NLRP12 gene mutation, which is known to be associated with chronic refractory ITP and autoinflammatory condition. Any experience with similar gene mutations and treatment modality? So, to any one of you, Dr. Anand or Dr. Vinay, any experience?
Sorry, I don't have any experience with NLRP. I've not looked after anyone. And Vinay or any of the others in the audience.
Yeah, even I have no experience with this. One of the problems we have when we send whole exome is this one, that we get either a heterozygous mutation or something which they label it. Like many times we get some this is like primary immunodeficiency type 45, 50 and things like that, or something that may. So I think we should, if we do not have a clear-cut consensus on treatment change, probably better to manage like a chronic ITP, refractory ITP with need of medication based on symptoms.
Okay, and the last question by Dr. Sneha, can NATE persist till 4 months of age?
I don't know. I'm not sure. The longest I've seen NATE is up to 3 months. I don't have any experience at 4 months. I'm sure that's what's worrying the person who asked the question. I wonder Vinay, Vasu, anyone else?
No experience. Till 6 weeks, we keep consoling the parents saying it will be okay. But beyond that, no experience.
Okay, so I guess those are the questions that were posted in the chat box. If there are no other queries, then we will end the session. I would like to thank Manisha from ECO platform. She has sent a link. Please give your feedback in the link, and thanks again to the ECO platform for providing this platform for the online training program, and special thanks to Dr. Vinay, Dr. Anand and Dr. Ranjita for making the presentation extremely it was very nice for the trainees and for everyone that has attended, and very simplified approach to thrombocytopenia. So thank you everyone.
Thank you.
Thank you.